Welcome back to the Virtual Transplant Journey 2024. Our next session is Living Your Best Life in the Post-COVID Era. Please remember, you can post your questions in the Q&A tab, and we will share with the speaker after the presentation as time allows. Dr. Seema Mehta Steinke, our next speaker, is a clinical assistant professor in the Division of Infectious Diseases at the University of Pittsburgh Medical Center. She is also telemedicine faculty for ID Connect. Her clinical focus includes transplant and oncology infectious diseases, providing infectious disease care for oncology patients, as well as organ and bone marrow transplant recipients, and providing telemedicine care to various patient populations across the company. Please welcome Dr. Steinke.
Good morning, everybody. Thank you for joining. Let me just share my screen. All right, so the talk today is titled Living Your Best Life in the Post-COVID Era. Just an abbreviation that I want everyone to be aware of, as I'm going to be using it frequently throughout this talk, is SOT, standing for Solid Organ Transplant. The objectives today to discuss the background of infection in solid organ transplant, explain the net state of immunosuppression, reiterate the infectious risks in solid organ transplant based on time post-transplant, and describe the various exposures that place SOT recipients at risk for infection. And lastly, we will review vaccine preventable illnesses and COVID-19. So just a little bit of background, solid organ transplantation has increased throughout the world since the first successful human kidney transplant in 1954, which was actually a living donor transplanted kidney performed between 23-year-old identical twins. Medicine as a field has improved our ability to suppress immune systems and have longer organ survival, but as a result, infection and cancer have become the primary barriers to survival after organ transplantation. Prevention of infection is vital to secure excellent outcomes. Infection remains a risk to SOT recipients even long after the initial post-transplant period. What factors affect one's risk include the patient's net state of immunosuppression, which I will briefly discuss in a moment, the exposures that that person has, and the consequences of invasive procedures that the SOT recipient may have undergone. So where do infections come from? They can be due to organisms within the body. We call these endogenous organisms. An example of that would be cytomegalovirus or CMV. They can also be due to donor-derived infections. And lastly, they can be due to environmental exposures. So it's truly a balancing act. The major goal of transplantation is to be able to lead a healthy and normal life, as normal of a life as possible. Risk of exposure to infectious agents will always be present, but SOT recipients should be counseled by their team on ways to minimize the risk of infection. And strategies for safe living must be incorporated into the SOT recipient's life as they move toward regaining normal function and returning to an active and productive life. So it's a balancing act between one's quality of life and the graft or organ survival. So some key items to remember. Sources for infectious complications include community-acquired, reactivation of latent infections, donor-derived, and nosocomial, also known as hospital-acquired infections. The inflammatory response in an immunosuppressed individual can be muted, and altered anatomy following transplantation may change physical findings associated with infection. Immunosuppressive drug levels provide a crude measurement of how immunosuppressed an individual is. That is the net state of immunosuppression. But patients are often more or less immunosuppressed than we anticipate. So what is this net state of immunosuppression? So it is a conceptual assessment of the factors contributing to the risk of infection in an immunosuppressed individuals. So this includes the type, dose, duration, and temporal sequence of immunosuppressive therapies that a person has received. It also includes underlying diseases and comorbid conditions. It also includes the presence of invasive devices. So if you have a vascular catheter for dialysis, for example, or a urinary catheter or a drain in place, or a ventricular assist device, those all play a part in the net state of immunosuppression. That also includes other host factors that affect immune function, such as low white blood cell counts, also known as neutropenia, low antibody levels, known as hypogammaglobulinemia, and then other metabolic problems like diabetes and things like that. And then simultaneous infection with an immunomodulating virus. That's a virus that impacts the immune system in a negative way, leading to more immune suppression. And these viruses include CMV or cytomegalovirus, EBV or Epstein-Barr virus, hepatitis C virus, hepatitis B virus, and HIV. So this is the sum of congenital, so factors you're born with, acquired, metabolic, operative, and transplant-related factors. That equals the net state of immunosuppression. And usually multiple factors are present in one individual. We can roughly measure the net state of immunosuppression by looking at a patient's white blood cell count, their immunosuppression drug levels, and noting the frequency and severity of common infections. So a variety of blood tests are being developed to better measure this concept in order to understand one's risk for infectious complications. But until that happens, we just have to have a crude measurement in our mind based on all these factors to tell us how immunosuppressed a particular individual is. And this is very individualized in that it is specific to each person and not something that can be similar in one person to another, even if those factors that they have are similar. It's still very different from one person to the next. So here's a pictorial representation of the net state of immune suppression. So you can see here the normal immune system is functioning generally at 100% most of the time, whereas if you have a transplanted organ, your immunosuppression may lead your immune system to be functioning at a fraction of what the normal immune system functions as. Over time, they may reduce your immunosuppressive therapies and things may get better and your immune system function may improve, but then you may have a bout of rejection, which then leads to suppression of the immune system yet again to a very high level. So this kind of tells you how this is a dynamic process, changes over time, changes in each individual, just based on the different factors that are present on a day-to-day basis. So what are some sources of infectious complications? As I mentioned earlier, we have nosocomial or hospital-acquired, donor or recipient-derived, reactivation of latent infections, and community-acquired infections. You can see here there's a timeline on the right side of the screen indicating that early after transplant, recipient and donor-derived infections play a role. Nosocomial infections also play a role early on. As we go out in time from the transplant, the community-acquired infections start to take more prevalence over the donor-derived and recipient-derived. But over this entire period of time, there's a constant dynamic assessment of one's infectious risks. So let's talk about this infection by time post-transplant. So the post-transplant course can be divided into 3 time periods. The early period, which is 0 to 1 month after transplant, the intermediate period, which is 1 to 6 months after transplant, and the late period, which is more than 6 months after transplant. Because the full impact of immunosuppression actually accumulates over time, the greatest risk for infection is actually in the second period, that intermediate period. Everything else is less than that, but that is your highest risk for infectious complications. And then, of course, any intensified immunosuppression, for example, for the treatment of organ rejection, essentially resets the clock back to your initial transplant period. So then you fall back into these early, intermediate, and late periods when trying to determine how at risk you are for infection. So the first month, two major causes of infection in all SOT recipients in the first month include pre-existing in the donor or recipient, and then infectious complications of the transplant surgery and hospitalization itself. Effects of immunosuppression are not yet quite obvious. The exception would be in those who are receiving immunosuppression before the transplant, for example, patients with lupus or rheumatoid arthritis, or those living with immunodeficiencies such as HIV. The first month, the donor-derived infections are unanticipated infections that arise from donor organ and are activated in the recipient. Some are latent infections, and some may simply be a result of bad timing. In other words, an unappreciated active infection at the time of donation. The efficiency of transmitting the infection from donor to recipient is enhanced due to immunosuppression, but that full effect of immunosuppression is not yet felt. Living and decreased organ donors are screened to avoid transmission of certain infections. Nonetheless, transmission of infection may still occur, albeit it is rare. Recipients of organs from donors who are known to be infected or considered at high risk for transmission of HIV, hepatitis C, hepatitis B, or COVID-19 actually require additional informed consent prior to transplantation. What about recurrent infections in the first month? These are infections that may have been present in the recipient prior to transplantation. So this includes hepatitis B, hepatitis C, and things like herpes simplex virus, which are essentially the viruses that cause cold sores and genital herpes. These infections can reemerge early after transplant. Moving on to the first month surgical and nosocomial infections, infectious complications related to the surgery and the hospitalization include pneumonia, surgical wound infections, bloodstream infections due to the presence of vascular catheters, and urinary tract infections. The organisms responsible for most of these infections are often the bacteria and fungi that live on or in the recipient and the donor. So moving on to the intermediate period of 1 to 6 months. The effect felt by immunosuppression at this time is maximal. Patients are at greatest risk for developing infectious complications during this time. And we give patients a variety of antibiotics, antifungals, and antivirals during this period to try to prevent infections from occurring. This may delay infection, but it does not eliminate the risk altogether, especially the risk of infection after the medicines have been stopped. And then moving on to the 6 and 12 months and beyond, patients are usually on stable immunosuppression and possibly even reduced amounts of immunosuppression at this time. But community-acquired infections, as I mentioned previously, are more commonly seen. So things like pneumonia and then community exposures are the main source of infections in this period. For the remainder of this talk, I'm going to focus primarily on these exposures as you'll see, when time goes on, it's easy to get relaxed in our ways, and that further increases our risk of being exposed to certain things that can cause infection. So what are some environmental or community exposures that I'm referring to? So there can be occupational exposures, recreational exposures, travel exposures, exposure to people, animals, or even water can pose as a risk for causing infection. As I mentioned, as time goes on, it's easy to become relaxed, but we just have to be cognizant and aware and informed in order to try and prevent these infections from occurring. So when we assess your risk, we need to understand what your risk is. So we're going to ask a lot of questions like, where do you live? Where were you born? What travel have you participated in, recent and remote? What pets, animals, or birds are you in contact with? What's your occupation and your hobbies? What are your lifestyle habits? What are some water and food exposures that you may be having? And what about sick contacts? So talking about where do you live, where were you born, where have you traveled, this matters because different parts of the world pose different infectious risks. So an example of geography playing a role, these are two different types of fungal infections, histoplasmosis and coccidiomycosis. These fungal infections are what we call endemic. In other words, they are present in our country, but you can see here that the distribution of these fungi are very different. So for histoplasmosis, we tend to see this in the middle part of the country and moving out eastward, whereas coccidiomycosis we tend to see in the southwest part of the country. So depending on where you were from or where you've traveled to may play a role in what infections you are at risk at acquiring. So this is just one example of several examples that I could give you about geography playing a role. But this is why when we ask you about travel, recent and remote, or where you were born or whatever, these are the things that are coming to our minds when we're assessing your risks. So what about some animal-related infections? So cat scratches can lead to cat scratch disease, which is from a bacteria called Bartonella. Cat litter can lead to a parasitic infection called toxoplasmosis. Reptiles are notorious for having salmonella. Monkeys can transmit a virus called herpes B virus. Chickens can transmit histoplasmosis, as well as another fungal infection called cryptococcus. Birds can transmit a bacterial infection called chlamydophila. Aquariums can transmit a bacteria called Mycobacterium marinum. Cat bites can lead to Pasteurella infection. Mosquitoes can lead to West Nile virus, Zika, chikungunya, dengue. Rodents can transmit lymphocytic choriomeningitis virus. And puppies, kittens, and chicks can also transmit Campylobacter, which is a bacteria that can cause a diarrheal illness. So as you can see, the variety of infections that one can be exposed to just from our household animals and just exposures to animals that are in our environment can be very broad and vast. So what are some key points about pets and animals? So do not get a new pet in the first year of transplant or during times of increased immunosuppression, for example, when you're being treated for rejection. Avoid sick animals, such as an example would be animals with diarrhea. Avoid kitty litter, cleaning bird cages, bird feeders, and handling animal feces. If you have to do these and can't avoid these activities, you should use disposable gloves and a surgical mask when doing these things. Avoid live vaccines in animals when effective non-live vaccines exist. For example, kennel cough. There are two forms of the kennel cough vaccine for dogs. One is an injection, which is a non-live vaccine, and the other is an inhaled vaccine, which is live. There have been case reports of that live vaccine, the inhaled one, being transmitted to lung transplant recipients. And then that lung transplant recipient comes down with essentially kennel cough. So it's very important that we are aware of these things and work with our vets to make sure that non-live vaccines are being given when it's feasible to do so. You should take your pet regularly to the vet for checkups. Avoid any stray animals, avoid contact with non-human primates or monkeys. Ensure that areas near the home are free from raccoons, and wear gloves to clean aquariums or have someone else do this. Essentially, you want to avoid scratching yourself when cleaning the aquarium, as that is what leads to that Mycobacterium marinum infection that I mentioned on the previous slide. Seek medical care if an animal bite or scratch occurs, and wash hands after handling pets or cleaning up after them. And avoid mosquito bites. So use DEET, use bug sprays and prevention methods to try and avoid getting mosquito bites. And lastly, hand hygiene and maintaining pet health are vital. So with all that being said, pets are okay to have. Despite the risk of infection from animals, there are many benefits to owning pets, and it's been demonstrated that solid organ transplant recipients have often had family pets without transmission of infection. The psychological benefits of pet ownership must be weighed against the potential risk for transmission of infection. And there was actually one study done looking at 89 lung transplant recipients, including 52% who were pet owners. And those people reported a significant increase in various metrics measuring life satisfaction, without any increased risk of hospitalization for infection. So 96% of the pets were obtained prior to transplant, and 91% of the pets were indoor pets. So having a pet is important, And having a pet is okay, but you just have to take the necessary measures and steps to prevent yourself from getting sick, especially if your pet gets sick or needs certain care that should only be provided by someone who is not a transplant recipient. So what if you work with animals? Those who work with animals should, if possible, avoid working during periods of intensified immunosuppression. And returning to work, solid organ transplant recipients should minimize their exposure to the potential infections by using proper precautions, including frequent hand hygiene and the use of gloves and masks when indicated. So if you have a dog with kennel cough coming in, usually the vet is aware of this beforehand, and they should use gloves, masks, gowns, and hand hygiene when caring for that animal. So let's talk about other occupations of SOT recipients. So we've seen people who are professional horticulturalists, infectious diseases, general surgery or ICU doctors, dentists, ICU nurses, criminal justice system worker, plant pathology laboratory worker, farmer, gardener, landscaper, construction worker, childcare teacher, special education provider, and pet store employee. You can see that the occupations of solid organ transplant recipients are varied and can pose a risk depending on what you do, but it's important you just take steps to protect yourself. So how can you make the workplace safer? So you want to avoid TB exposures or tuberculosis exposures. So that's often at shelters like homeless shelters, jails, nursing homes, immigration office, places where the TB exposure can be high are these locations. So it's important to avoid these locations, or if you have to go to them, it's probably best if you wear an N95 or a KN95 mask, as tuberculosis is spread through respiratory droplets. You should wear gloves when handling soil or dirt. So if you're planting, gardening, etc., you should wear gloves. Wear masks or respirators when fungal spores may be aerosolized. So that's like in dust, so construction sites, when you're laying down mulch in your lawn, or if you're digging dirt. Keep in mind that home renovations can occur, but it's prudent for transplant recipients to avoid exposures, particularly early after transplant or after rejection treatment, or any time after a lung transplantation. You should avoid exposure to animal feces, including bird feces. So avoid chicken coops or cleaning out chicken coops. And then meticulous hand hygiene in all situations, even if gloves have been worn, is vital. You should wear a mask or a respirator if exposure to the above is unavoidable. And then use common sense. If it feels unsafe, it likely is. So if something in you is telling me maybe I shouldn't do this, you probably should listen to that gut feeling and have someone else help you with whatever project or activity it is that you were about to embark on. What about hobbies and their associated infectious risks? So gardening, laying mulch, as I mentioned on the previous slide, you can have fungal spores aerosolize during that, and you're at risk for aspergillus and other fungal infections. So you should use gloves and a mask and avoid being in the garden barefoot, because there are certain parasitic infections that actually enter through our skin, and those parasites live in the soil and grass. Carpentry, similarly, fungal spores can be aerosolized, so fungal infections and histoplasmosis are common, so you would want to use a mask or a respirator. Hunting can lead to trichinosis and cryptosporidium, so parasitic infections. So you should avoid doing the field dressing yourself. You should cook all meat thoroughly, and don't drink the water when you're out hunting. Always bring proper bottled water or filter water of some sort. Don't drink fresh streams or anything like that. And then fishing, scuba diving, you're at risk for Mycobacterium, Vibrio, Cryptosporidium. So the biggest things you need to do is avoid injury during your water sports. And again, don't drink the water. And then spelunking is actually a risk factor for other fungal infections, specifically Cryptococcus and histoplasmosis. So you should wear a mask and gloves. And lastly, contact sports. You should take caution to avoid injury to the graft or organ. So if you're a kidney transplant recipient in particular, you would know that your kidney is more superficial and more easily injured if you are playing a contact sport. So you need to take extra cautions. And then hands should be washed after activities, even if gloves were worn. So I know that during this COVID-19 pandemic, we were all very heightened and aware of hand hygiene. That should be carried through for all transplant recipients, as it is one of the most effective ways to avoid infection transmission. Let's move on to recreational drug use. So marijuana, smoking or vaporization of marijuana can lead to fungal infections. So if you're going to have any marijuana products, eating it is preferred to smoking. But I think there are talks on marijuana specifically, so I won't go into more detail about that. LSD, meth, cocaine, heroin, these are all laced with unknown substances. And then prescription narcotics can lead to drug-drug interactions with other drugs that you're taking for your organ, like your immunosuppressive drugs. And so it's really important that you're only using what your doctor prescribes for you. Let's move on to sexual practices. So what are some safe sexual practices that we can participate in? So use latex condoms outside of monogamous relationships. And consider the use of latex condoms during sexual activity, even with long-term partners, but during periods of increased immunosuppression, so early after transplant and during periods of treatment for rejection. Avoid exposure to feces, and you should be vaccinated against hepatitis B and human papillomavirus when appropriate. The goal is to reduce sexually transmitted infections like hepatitis B, hepatitis C, HIV, cytomegalovirus, human papillomavirus, and herpes. What about other lifestyle things that we tend to do, like tattoos and body piercings? So these represent a break in the skin, which can lead to infection. Generally speaking, these are not encouraged activities, but if body piercing or tattoos are to be obtained, reputable centers with good sterile techniques should be used. And self-piercing or tattooing or sharing of needles should be avoided. Okay, let's move on to some food safety. So we should avoid unpasteurized products like juices, dairy products, ciders, cheeses. When you're getting soft cheeses in particular and moldy cheeses, you should check the labeling as those can often be unpasteurized. What are we at risk for with unpasteurized products? E. coli, Salmonella, Listeria, Cryptosporidium, Yersinia, and Brucella are all infections that we are at risk for. And then you should avoid raw or undercooked eggs. So uncooked cake or cookie batter, some preparations of Caesar salad dressing, mayonnaise, and hollandaise sauce are all risk factors. The primary concern would be salmonella here. You should avoid raw or undercooked meat, poultry, or fish. You're at risk for a variety of bacterial and parasitic infections, including tapeworms with that. Avoid raw or undercooked seafood, so like sushi, ceviche. You're at risk for bacterial, viral, and parasitic infections there. Avoid ingesting raw seed sprouts, so like alfalfa, mung beans, etc. I personally love these, but these are very difficult to wash, and it's just a very strong risk factor for a variety of bacterial infections. So avoidance is key with those. Avoid cross-contamination during food preparation. Avoid uncooked pate, meat spreads, cold cuts, and smoked seafood because these items are not cooked to a temperature, an internal temperature high enough to kill bacterial pathogens. And then you should wash all fruits and vegetables, even if the labeling says pre-washed. Avoid eating at public salad bars, buffets, street vendors, picnics, where food has sat out at room temperature for an extended period of time, or at potluck meals where hygiene standards of all participants are not known. And then avoid eating food prepared by someone with a recent diarrheal illness. So recent would be sometime in the last couple of weeks. So let's talk a little bit about water. So waterborne infections most often occur due to the consumption of contaminated water or inadvertent water ingestion during recreational activities. Cryptosporidium is the main concern here, and this can cause a severe chronic diarrheal disease. This parasite is actually resistant to chlorine and can rarely be found in treated water sources. So to eliminate all risk, you should bring your water to a rolling boil for at least 1 minute, or if you're at elevations greater than 6,500 feet, 3 minutes, and utilize personal filters or consume bottled water. Ice and fountain beverages may be made from untreated water, so it's very important that you're cognizant of that if you're out traveling somewhere, especially in parts of the world that are underdeveloped. Ice in your drink can lead to infection as well. So just a brief slide on about water filters and bottled water. Water filters should have an absolute pore size of less than 1 micron or should be tested and certified to the NSF ANSI standard. And here's a link to that particular standard. And then bottled water information can be obtained from the International Bottled Water Association. And they have a great ton of information about bottled water and how to make sure that it is safe and appropriate water for consumption. And then lastly, the CDC also has information devoted to bottled water technologies as it relates to cryptosporidium risks. So I would highly recommend checking some of these websites out and just familiarizing yourself with them. There's so much information that it's hard to put into this talk, but these sites are really good sources of information. So some pearls of wisdom when it comes to water exposure. Public or private well water, especially in areas that are not screened frequently for bacteria, should be avoided if possible. If used, it should be tested yearly for microbial contamination, and it's safer to boil well water or use bottled water for drinking and brushing your teeth. Do not drink directly from lakes and rivers. Avoid swimming in water that is likely contaminated with human or animal waste. Avoid swallowing water during swimming. To avoid spreading infection to others, solid organ transplant recipients who have had a diarrheal illness should avoid using public recreational water facilities until 2 weeks after symptom resolution. Hot tubs should be avoided. Standing water in the home or basement, for example, from flooding, should be promptly cleaned and avoid growth of mold. This should not be done by the SOT recipient. If it's unavoidable, though, use gloves and a mask during cleaning. And when traveling to countries with poor sanitation, one should avoid drinking tap water and inadvertently consuming ice cubes or water while brushing teeth or showering. And if an abrasion or cut occurs while bathing in the ocean or fresh water, it should be immediately and thoroughly cleaned with an uncontaminated water source. So for example, with bottled water. So let's move away from food and water and whatnot and talk a little bit about respiratory illnesses. So sick contacts are a big way we get respiratory infections. So it's important to avoid crowded areas, and those who are sick, you should wear a mask and you should practice hand hygiene. I feel like these are things that we just do normally now ever since COVID has been an issue. Let's talk briefly about diarrheal illnesses, which those same rules about respiratory illnesses that we just talked about, avoiding crowds, avoiding sick contacts, hand hygiene, etc., that also applies to diarrheal illnesses. So if someone in the home is sick with diarrhea, cleaning and disinfecting surfaces in the home is important. Some causes of diarrheal illnesses, such as C. difficile and norovirus, are resistant to commonly used cleaning and disinfecting products. In fact, in these situations, bleach needs to be used. If someone in the home has a diarrheal illness, whether it's the transplant recipient or someone else, rubber or disposable gloves and a bleach-based cleaner should be used on environmental surfaces, especially in the bathroom and the kitchen. And the CDC website includes a video on how to clean up after vomiting and diarrhea from a person with norovirus infection. And this is actually a really helpful video on how to just clean up and ensure that you don't get sick from touching contaminated surfaces. So let's go back a little bit to respiratory infections. So specifically flu and other vaccine preventable illnesses. Close contacts of solid organ transplant recipients can transmit infection that can be particularly harmful to the SOT recipient. Vaccination against flu and other diseases like measles, mumps, rubella, varicella, Tdap. These are all encouraged for everyone in contact with, but particularly for those involved in the care of solid organ transplant recipients. All household contacts should be instructed on good hand hygiene. So hand washing, coughing and sneezing etiquette, and covering open wounds. They should also receive their yearly flu vaccine and ensure all other standard immunizations are up to date. And contacts at work and school should also be encouraged to receive their vaccinations. So let's talk about the RSV vaccine. This is a newer vaccine that came out recently. RSV stands for respiratory syncytial virus. And this vaccine is specifically approved for those who are pregnant, some infants, like very young children, and then those who are 60 years and older. And I'm going to focus on the 60 years and older patient population. There are 2 RSV vaccines licensed for use in adults aged 60 years and older in the US. That's the GlaxoSmithKline Arexvy and the Pfizer Abrysvo. Shared clinical decision-making is used to determine if this is right for you. So what is shared clinical decision-making? That is having a conversation with your provider, with your transplant team, with your doctor to determine if getting this vaccine is right for you. People at high risk for severe RSV disease are those with cardiopulmonary disease, kidney disorders, neurologic disorders or neuromuscular conditions, hematologic disorders, diabetes, or those who are moderate to severely immunocompromised, for example, solid organ transplant recipients. So the timing of the vaccine should be given in late summer, early fall, so that it is effective for the late fall and through the winter. The number of doses that one is to receive is 1, but studies are ongoing to determine if additional doses will be needed. At this point in time, the data suggests that 1 dose will cover you for 2 RSV seasons, so essentially 2 years. It's a well-tolerated vaccine. There are some side effects like fatigue, headache, injection site pain, which is common to most vaccines. And severe adverse reactions were noted in 4% of the GlaxoSmithKline vaccine and 1% of the Pfizer vaccine recipients. And a small number, total of 3, neurologic adverse events occurred in about 20,000 participants, and a small number of 10 recipients had atrial fibrillation, which was difficult to determine if it was related to the vaccine or not. But similarly, that was 10 out of about 20,000 people in both studies. So let's move on to COVID-19 briefly. As per the American Society of Transplantation, it is important that as a solid organ transplant recipient, you get vaccinated. You should get vaccinated against both COVID and flu. You should wash your hands frequently with soap and water for at least 20 seconds, or use hand sanitizer with at least 60% alcohol content. Avoid touching your face, eyes, mouth, nose. Avoid large crowds. Wear a well-fitting mask if you are going to be in crowded spaces indoors. Practice social distancing. Stay at home if you are sick. And ensure household contacts avoid risk situations and receive all standard vaccinations, including the flu vaccine and the COVID vaccine. And then continue safety measures even if you are COVID vaccinated. So what about the COVID vaccine and solid organ transplant recipients? Now, things have changed. The landscape of COVID has changed since its beginnings, and the vaccine that is now available is different than what it was previously in that it is more focused on the variants that are prevalent nowadays. It is still recommended, strongly recommended, that immunocompromised patients received the COVID-19 vaccine. And the latest vaccine is the 2023-2024 COVID-19 vaccine directed at the Omicron variants, and it's made by either Pfizer or Moderna. So who is deemed immunocompromised here? So this slide is, sorry about that. This slide is the moderate to severe immunocompromised patients that may have a suboptimal COVID-19 vaccine response. So anybody who's receiving treatment for a solid tumor or a hematologic malignancy like leukemia, people with solid organ transplants, you can continue to read the slide here. There's, people with HIV, people who are being treated with steroids, anti-metabolites, transplant-related immunosuppressive drugs. These are all the patients that are at risk for having severe COVID infection. And solid organ transplant recipients are on this list. So what about the vaccine efficacy? Vaccine effectiveness is decreased in the SOT population, but weighing less effective vaccines against severe COVID illness, the benefits of the vaccine outweigh the risks of severe COVID illness. So in a study from Israel looking at over 1 million people who received at least one mRNA COVID vaccine showed efficacy in immunocompromised patients of about 75% compared to 94% in non-immunocompromised recipients. In transplant recipients, those receiving B-cell depleting agents, such as rituximab or Rituxan, and those receiving mycophenolate, also known as CellCept, or azathioprine, and those who have been recently transplanted have decreased vaccine efficacy. So what is the vaccine schedule for SOT recipients now? So if you've been unvaccinated, so never received a COVID vaccine previously, you should receive 3 doses of the 23-24 vaccine. And for the interest of time, I will not go into the exact details of all of this, but you just need to know that you need to receive 3 doses. Those who received 1 dose of a previous COVID-19 vaccine should receive 2 doses of the 23 and 24 COVID-19 vaccine. And those who received 2 or more doses of a prior COVID-19 vaccine should receive at least 1 dose of the 23-24 COVID vaccine. But because we're talking about immunocompromised patients, there's always 1 more dose that we have to give. And this has been the story since the beginning of the COVID pandemic. For those who are 65 years and older and received appropriate vaccines as outlined on the prior slides, it is advised that an additional dose of the 23-24 vaccine is given 2 months after the last dose was given. And the CDC does allow for additional doses in those younger than 65 years of age in specific situations. So people who are receiving B-cell depleting agents, as I mentioned previously, rituximab, also known as Rituxan, receiving stem cell transplantation or bone marrow transplants, and receiving CAR T therapy, which is a very specific type of therapy for certain types of cancers. So does all this mean we can stop taking preventative measures if we're fully vaccinated? The short answer is no. Unfortunately, we can't. The long answer is it is still recommended that SOT recipients take personal measures such as masking, avoiding large crowds, avoiding sick contacts, etc., largely because of the reduced efficacy of the vaccine in this patient population. Household and other close contacts of immunocompromised patients should be fully vaccinated as well, and know that breakthrough infection in vaccinated SOT recipients does occur and can be severe. The incidence of this is not high, but it is higher in the SOT population than the vaccinated general population. So I'm going to end my talk here with prevention is better than cure. This is true in so many different ways, but when it comes to infection and SOT recipients, prevention is truly better than cure. These are my references, and thank you so much for your time and attention. And if there are any questions, I'm happy to take them now. So it looks like there's a question in the Q&A stating that this person developed post-transplant lymphoma. Does cancer develop from environmental factors, and are we more susceptible because we are immunosuppressed? So I'm sorry, first of all, that you developed post-transplant lymphoma, but cancer does develop as a result of some of these viruses that I mentioned early in my talk. If you develop something called post-transplant lymphoproliferative disorder, that is more than likely related to an infection from EBV or Epstein-Barr virus. Now, that virus is something that most of us, like 80% of the population, has been exposed to this virus by the age of 6 or 8. So it is a very prevalent virus in our community. And I think, you know, that if you consider that an environmental factor, which I do, I would say that in this case, post-transplant lymphoma is more than likely from environmental factors. And yes, you are certainly more susceptible because you are immunosuppressed. The drugs you receive to try and keep your organ alive and healthy is the reason why things in our immune system don't function well when it comes to infection and when it comes to cancer. It's an unfortunate reality, but those are the things that we need to be aware of now, because solid organ transplant recipients are living to much older ages. And that, as a result, means that infection and cancer are more common and more prevalent. So medicine has to do better. We as a medical community have to do better, but we're trying. Some of these things are really hard to try and avoid. And it's hard to balance these things. As I mentioned early on, it's a very fine balancing act. I hope
Thank
that
you.
answered your question.
Thank you, Dr. Steinke. I think that is the only question that was in the Q&A chat, but I wanted to thank you for sharing your time and insights with our group. And so I'll give, oh, there's one more question that popped up in the Q&A. I was going to say, and to the rest of the group in here, we can take questions for the next 2 to 3 minutes. So if you have an additional question, please type it right now in the Q&A. Okay.
Yeah, so the next question, sorry.
I can read it to you, or you can read it.
I'll read it.
Okay.
So do our bodies ever accept transplanted organs over time without immune suppression drugs? So that's a very challenging question to answer. The short answer is, in very specific instances, someone can be off of immunosuppression, but it's usually in the setting of the organ failing. So generally speaking, we do need immunosuppression to allow our body to accept the transplanted organ. I've seen instances where people have become non-compliant with their transplant medications, and as a result, they develop acute rejection with very high fevers and things of that nature. So in general, the immunosuppressive medicines are absolutely necessary for the organ survival and acceptance in the body. So I wish we had a way to keep these transplanted organs over time without immunosuppression, but unfortunately at this time it's not possible.
Thank you, Dr.
I'm happy to
Steinke.
take, I'm happy to take additional questions.
We'll give everyone just 1 more minute, Dr. Steinke.
Sure, no problem.
Okay, well, on that note, again, thank you all, and we'll see you at our next section. This concludes this current session.